Thank you so much for that kind introduction, and I'm looking forward to speaking with all of you today. I know sometimes when you're feeling poorly, it's not your best day, and you're going to see your GI doctor. Thinking about preventative care is probably the last thing on your mind. You're thinking about first, I just want to get better. But I bring this topic up, and it's very near and dear to my heart because at some point you will feel better. We have so many wonderful medications to treat our patients now, and so I guarantee you, if you haven't gotten to this yet with your doctor, you certainly will. These slides are moving without me. Hold on. Okay, there we go. So today we're going to review the various aspects of health maintenance, so including immunizations, also bone health, cancer prevention strategies with regards to preventing colon cancer, skin cancer, as well as cervical cancer. Mental health is also a really important part of maintaining your health. If your mood is down and you're lacking energy and just don't feel like taking your medicine, then things are certainly not going to get better, they're going to get worse. So let's start off first talking about immunizations, which are a very important part of health maintenance. So in general, vaccines can help prevent various infectious diseases, and patients with IBD are at an increased risk for developing many of these vaccine-preventable diseases. And this risk is further exacerbated by medications that can suppress the immune system. Probably the biggest culprit is corticosteroids. However, immunomodulators, biological molecules, and small molecules also can increase that risk. And so these are just some of the examples. So pertussis, also known as whooping cough, shingles, pneumonia, which is caused by the pneumococcal bacteria, hepatitis B virus, mumps, and the flu. And now the biggest one we've all been facing is COVID. And so here's a more complete list of some of these vaccine-preventable illnesses that you can certainly address with your primary care doctor. And if there are any concerns about whether these vaccines are safe, it would be reasonable to also bring up with your gastroenterologist as well. And so in general, vaccination rates of IBD patients are extremely low. An older survey that was done out of 169 patients, only 28% had received the flu vaccine and only 9% had received the pneumococcal pneumonia vaccine. Now, with many of these immunosuppressive medications, one of the most common risks is developing pneumonia or flu-like symptoms. And so it's really important for our patients to strongly consider getting immunized to help further reduce that risk. Some of the potential reasons for why IBD patients have lower rates of vaccination, gastroenterologists felt that primary care should really be doing this, but then the primary cares may feel that, well, these are medications I'm not totally comfortable with, I'm not familiar with. I would feel more comfortable if the gastroenterologist did. And so probably the reality is that either of them could do it, but I think it's important as a patient to really advocate for your own health and be aware of some of these vaccines that are available to you and could be beneficial to you. I think also sometimes with the GI visits, you have so many things to discuss just regarding your medications and the lab safety monitoring, and there are so many aspects to health maintenance for inflammatory bowel disease that sometimes just when you're going through the disease process and the counseling, you may not have enough time to address the health maintenance. So these are some of the barriers that have been identified. And finally, many people just don't trust vaccines. There's a lot of fears and concerns. I always get the flu after I get the flu vaccine, or I'm worried that I might drop dead from the COVID vaccine. I know some person that happened to one person. And so, people have all sorts of fears, but I think it's worth a conversation and it's worth listening to your doctor's opinion. And at the end of the day, a lot of these are, guidance with anything. We have to use shared decision making. And really, I feel I wouldn't be doing my job as a doctor if I didn't address it with my patients, even if they seem a little bit hesitant. I've had many patients think about it and come back and change their mind. And so then when you think about, well, what's the timing, what's the best time to give these vaccinations? So typically we try to address this when the inflammatory bowel disease is in remission. Also, it's important to consider prior to starting medication that suppresses the immune system, if that is a possibility, if your disease can wait a couple weeks. For inactive vaccines, typically we will give that 2 weeks before starting. Or for live vaccines, those really need to be given 4 weeks before starting. You do not want to take live vaccines while you're on immunosuppressive therapy. And it's important to remember that treatment decisions and starting therapy for someone who needs it really should not be delayed just for the sake of giving a vaccine. If you're feeling terrible, there's no point in preventing things. We got to get you better now first. And if not available in the GI clinic, then if a clear recommendation from GI is given to you, then you can take that over to your primary care. And certainly those vaccines should be available in your primary care doctor's office. So then you might be wondering, okay, I know what medicine I'm on, but is this considered a medicine that prevents me from getting a live vaccine? So on the left here, you can see the full list of what's considered to be immunocompromising or immunosuppressive medications. So you'll notice, for example, that mesalamine is not on this list. If you're on mesalamine, you're not considered immunocompromised. That's a topical therapy. Even if you're on a very low dose of prednisone, 5 milligrams, for example, that's technically not considered immunocompromising. However, if you are on more than 20 milligrams a day for at least 2 weeks, then that is considered immunocompromised. And so you can see that the immunomodulators, the anti-TNF therapy, the IL-12/23 therapy, the sphingosine 1-phosphate receptor modulator, and the JAK inhibitors are all on this list for immunocompromising medications. So the list of live vaccines to avoid if you fall into that category on the left would be the MMR vaccine, varicella vaccine, the live intranasal flu vaccine, but getting the regular flu shot in your arm would be fine, yellow fever vaccine, and then the older herpes zoster or shingles vaccine was a live vaccine, but the newer vaccine that came out in the last couple of years is the herpes zoster adjuvant recombination vaccine, and that one is safe even if you're immunocompromised. And in fact, it's probably a good idea to get it, especially before you start a JAK inhibitor, because those medicines are known to increase the risk of shingles. So with the small molecules, it's an even stronger reason to get it. And that one is approved for anyone actually over age 50, even if they're not immunocompromised. So then let's talk about some of the newer vaccines, because some of these other ones you may have already had or you may already be familiar with. And so let's talk about the COVID vaccine. So for someone who's immunocompetent, so that might be someone out here who's not on any medicine for their inflammatory bowel disease, maybe they had surgery and they're one of the lucky ones without disease recurrence, or maybe only on mesalamine, those people would get 2 doses of an mRNA vaccine and then a booster after 5 months, and then a single dose of the Janssen vaccine followed by a booster after as soon as 2 months. It is safe if you got the J&J vaccine to then get the mRNA vaccine. In fact, those people had an even better immune response. Now, if you're immunocompromised, this schedule is a little bit different. Interestingly, data has come out that for the immunocompromised, those who only got 2 doses of the mRNA vaccine, that's almost the same as being unvaccinated. Really, it takes 3 doses to be considered fully vaccinated. And for the Pfizer vaccine, that's 3 of the same type of dose. And for the Moderna vaccine, that's 3 full doses. So the Moderna booster is a half dose, but your 3rd dose really should be a full dose. So if you go to the pharmacy or anywhere that's giving you your vaccine, it's really important to know, for them to know that you're immunocompromised, so they give you the right dose of the vaccine. And then for the J&J vaccine, you get your 1st dose, the booster, and then now for the immunocompromised, it's not just 1 booster. Many of you may have already had 2 boosters at this point. The Omicron-specific booster is most likely going to be coming in the next month or 2. Now, for those of you who are fully vaccinated against COVID, or you may say, I'm someone who I tried to get it, I got the 1st dose, but I'm allergic to a component and I had a reaction, I couldn't get the rest of it. So there is something called Evusheld, and this is something that you can ask your doctors about. And so it's an antibody and intramuscular injection. It comes in 2 vials, and so you would get 1 shot on one gluteus, another shot on the other gluteus, and they would monitor you for about an hour afterwards. And this is an antibody that helps prevent severe COVID, and it lasts for 6 months in your system. because the concern for those who are immunocompromised is that the vaccines do work in preventing severe COVID, but it's unclear whether the antibodies and the preventative benefits last long enough, it's unclear if it lasts as long as it does in an immunocompetent person. And so for many of my patients who are fully vaccinated, we're already giving that Evusheld, and so you can ask your doctors about that as well. Especially just being a practical person, I felt that over the summer things tend to be better, but every year it seems to be very bad in November, December, and January. And so for most of my patients, I'm giving it now in August and September, so that way they should be protected through February. If in case for some reason their vaccine isn't lasting the full amount of time that we would expect. So the other newer vaccines, this recombinant herpes zoster vaccine, this one is an alternative to the old live vaccine. Where the old live vaccine was sometimes less than 50% effective, this new one is 96% effective. It's 2 doses that you get, and again, anyone over age 50 is eligible. The hepatitis B vaccine, so some people who got the traditional 3-dose vaccine, for whatever reason, they may not have had a proper antibody response to getting it. And so now there's a newer hepatitis B vaccine that's only 2 doses that you give 4 weeks apart. So that could be something to consider if you're not immunized against hepatitis B. And then finally, regarding preventing pneumonia, which is the most common complication from being on many of these immunosuppressive therapies, before we used to give Prevnar followed by Pneumovax, but now there's a new vaccine called Prevnar 20. And so if you get this one, it's a one-time dose and you don't need multiple doses, you don't need boosters of it. So these are some of the new ones to be aware of that you can ask your primary care or your GI doctor. All right, so enough about immunizations. Let's move on to some bone health. So in general, IBD increases the risk for developing osteopenia, osteoporosis, as well as fracture. Some of the factors that further increase this risk include steroids, untreated inflammation, and poor nutrition. And so as part of the prevention, if you do have osteopenia or osteoporosis, if you don't have it, then it's a good idea if you're on steroids to consider taking a calcium and vitamin D supplement, but then also to consider doing a DEXA scan, which is a bone density scan to evaluate for whether you may have a weakness in your bones. If you've had a cumulative steroid use for more than 3 months, if your age is over 60 or postmenopausal, or if you have a prior history of fracturing easily, even despite the trauma being so low. And so these would all be reasons to consider getting a bone density scan. All right, so preventing colon cancer, I know, is always at the forefront of every IBD patient's mind. And the good news is now with so many wonderful therapies for IBD, people are having less untreated inflammation, and so the rates of colon cancer are really going down. But we can further reduce that risk through colonoscopy and some of our newer colon cancer detecting techniques that we use during our procedures. So remember that if you have less than 1/3 of your colon involved in Crohn's, or if your ulcerative colitis only involves the rectum, you technically don't have an increased risk of colon cancer. And so you probably don't need to be doing a colonoscopy every year. Of course, if you're having flare-ups or your doctor is trying to do other assessments, certainly you may need it. But I would definitely keep in mind your extensive disease when making these decisions. So then you treat inflammation to the goal of targeting endoscopic remission. So the goal is that we want you to feel well, but we want to make sure that the inside of you matches the outside and that we can really see that nice shiny tissue. And that really helps us see whether or not dysplasia or precancerous changes are present in the colon. And so if there's untreated inflammation, this can increase the risk of developing colitis-associated neoplasia or even cancer. It also makes precancerous growths very difficult to see. And so this is why it's really important to stay on your medicine if your doctor wants you to stay on your medicine, because even though it may seem like, well, I still feel okay even if I space out a little bit, it'll be okay if I miss an injection or an infusion, what you don't want is for your intestine to still have some brewing inflammation there, and then that's really the only thing that you have in your control to prevent a colon cancer, because you can't help the extent of your disease, you can't help your family history, you can't help how long you've had this. Patients with IBD live a long, long time. And so I see many young faces in the room, and you're going to have a long, great life ahead of you. And you don't want to be dealing with a colon cancer or big growths when you're 80 or 90 years old. So I definitely encourage you to work on making sure you stay on your medicine and heal that inflammation. And then screening starts 8 years from diagnosis. And typically we will do a colonoscopy with a high definition scope. And then some of the newer things that we do are virtual chromoendoscopy. So this is just a button that we can press on our scope that helps us see the lining of the colon better and helps us find any changes in that lining more easily so that we can go ahead and remove it. There's also dye spray chromoendoscopy, where we spray a blue dye in the colon. After this type of procedure, you may find that you're pooping blue and peeing green for a few days, so don't be alarmed if you happen to see that. But in someone who has had prior dysplasia that was not visible but picked up on a random biopsy, and there are very specific situations where we might consider spraying this blue dye, it can really be helpful in identifying and removing precancerous lesions. So I'll show you a picture of what that looks like. So you can see here, I'll just use this. So you can see here, this just looks like normal tissue, but then when you spray the blue dye, you can see that there is something there, and we would go ahead and remove that using our tools during the procedure. If this colon was very inflamed, I don't think my eye would even be able to pick this up. And if you're not in endoscopic remission, the tough part is that dysplasia sometimes does not pick up the dye. That's how it can pop out and we can see it more easily. But inflammation also does not pick out the dye. And so if you're actively inflamed, then a lot of these virtual and dye spray chromoendoscopy techniques cannot even be used in you. So I can't emphasize enough the importance of going into a good remission. All right, so the other update since the pandemic is that now there are some new colon cancer prevention guidance that have been published. And so really the timing of the next colonoscopy, if there's no dysplasia present, can actually be spaced out in very select patients. So I put this up directly from the paper that we have all read and studied well. So there are certain patients that definitely need a colonoscopy every year. So if they've had moderate or severe inflammation on the exam, if there's a personal history of having primary sclerosing cholangitis, a family history of colon cancer in a first-degree relative, age less than 60, if you are someone who has had prior severe colitis and you have a lot of pseudopolyps. So pseudopolyps don't themselves grow to cancer, but it just indicates that that area has been severely inflamed and might be more at risk of developing precancerous changes. Or if there's been a history of higher risk visible dysplasia within the last 5 years, those people will not have an opportunity to space out. People who could space out to every 2 to 3 years, and again, remember, this is for people who are in remission and they had a colonoscopy that looked normal without dysplasia. If there was only mild inflammation, so they have healing of the ulceration, but maybe just a little redness or, it doesn't look perfect yet, but it looks very good, those people could space out to 2 to 3 years. Also, those with a family history of colon cancer that's pretty strong, but no one under age 50. Features of prior severe colitis, such as moderate pseudopolyps or extensive scarring. A history of invisible dysplasia or higher risk visible dysplasia, but it's been more than 5 years. Your doctor removed it and they can't, nothing's growing back, then it could be reasonable to space out to 2 to 3 years. Or if there's a history of lower risk visible dysplasia within the last 5 years. Then finally, I know this category is very interesting to everyone, 5 years. Imagine a life with 5-year gap in colonoscopy. So those who've had continuous disease remission since the last colonoscopy, so this is not a reason to lie about your symptoms, but we really want to make sure that you have had no flares in between, and that the last colonoscopy did show mucosal healing, meaning that because it was not ulcerated, your doctor could get a very good look. and that you've had 2 or more consecutive exams without any precancerous findings. And also the patients that we talked about who had only proctitis with ulcerative colitis or less than a third of the colon involved, those could also fall in this 5-year category. So something to pay attention to, and don't be alarmed if you see that your doctor spaces out your colonoscopy, because I know when you're used to getting it done every 1 year, every 2 years, it can feel scary to space out. You know, I know nobody in this room wants to end up with colon cancer, but if your doctor's spacing it out, that means that they feel comfortable and confident that they got a good look in you and that you're doing really well. All right, and then we'll move on to preventing skin cancer. So people with inflammatory bowel disease do not have an increased risk of skin cancer. However, being on certain medications can increase the risk of skin cancers. So typically, anti-TNF medications can increase the risk of melanoma. So this is infliximab, adalimumab, certolizumab, golimumab. Thiopurines, such as mercaptopurine or azathioprine, do increase the risk of non-melanoma skin cancers. So if you need to be on these medicines, I think the key is the preventative aspect. Wear sunscreen with a good SPF, wear protective clothing in the sun, avoid tanning beds, exposure to UV light, and keep up with your dermatologist, especially people who have fair skin and an extensive sunburn history. You definitely want to keep up with your dermatologist. All right, and then we'll move on to, if you want to take a picture, you can do, Rachel. Okay. And then preventing cervical cancer. So women with IBD are at an increased risk for developing cervical neoplasia, depending on the medicine they're on. So immunomodulators like azathioprine and mercaptopurine do carry more of a risk compared to steroids and 5-ASA agents like mesalamine. Anti-TNF agents are not associated with an increased risk. So HPV is the virus that's associated with 70% of cervical cancers, and so there is a vaccine for HPV, and actually they've extended the age. So initially they said age 11 to 26, but now actually anyone up to age 45 can get it, especially if they've had normal PAPs and do not have a HPV virus. And so I think it's good to speak with your gynecologist or your primary care to see, should you be someone who should consider an annual pap smear, especially if you've not had the opportunity to be vaccinated against HPV, or if you're on the immunomodulator medications. All right, and then mental health. So I work at the Atlanta VA, and so we have to have a depression screening on every single one of our patients, and we have walk-in mental health services like 5 doors down from my clinic room. And so I think that this is not unique to the veterans. This is for everybody, that people with IBD are twice as likely to report depressive symptoms. It's really important that you undergo some sort of screening for anxiety or depression, and this can even just be through self-reflection. Over the past month, have you felt down, depressed, or hopeless? Have you felt little interest or pleasure in doing things? If you are feeling that way, I think it's very reasonable to bring up to your doctor, either primary care or see a mental health specialist if there's any concern. Sometimes this can go along with flares, but sometimes they can persist even when flares get better. And so when your doctor is looking and saying, well, you're doing well on your medicine, you're not anemic, I don't have a reason, this is definitely something to think about. All right, and smoking cessation. So it's well documented the negative effects of tobacco and Crohn's disease. It's associated with increased flare-ups of Crohn's, also increases the risk of, smoking is associated with the development of Crohn's, but also increases the risk of Crohn's flares. It increases the need for surgery, as well as it increases the risk of recurrence after surgery. And smoking cessation in Crohn's does decrease the risk of flares. Now, the tricky part is with ulcerative colitis that smoking cessation may actually be associated with flare-ups of ulcerative colitis. I think that being said, when you start smoking again, it doesn't really make the colitis go away, so it's still better for all patients to avoid starting smoking and stop smoking if they are smoking. Especially, I know you've heard a lot about some of the newer medicines that Dr. Beard spoke about, the small molecules like tofacitinib, ozanimod, and upadacitinib. And so a lot of these medications are not recommended for people who are actively smoking because of the major risk of cardiovascular events. And so I think if it's not just even for your overall health, it's going to affect your treatment options. And so there's no place like the present to make a decision that you want to stop and make sure you address that. Primary care has a lot of tools up their sleeves to help support patients in quitting tobacco use. All right, so that's everything for health maintenance. So my take-home points for you are health maintenance does matter. Make sure you talk with both your gastroenterologist and your primary care and keep up to date. If you took any notes during this talk about things that you weren't sure if you've gotten, ask your doctors. Make sure you advocate for yourself and bring it up. Some new vaccines to consider: the shingles vaccine, the HPV vaccine, the new pneumonia vaccine, the new hepatitis B vaccine. Considering your COVID vaccine or booster, Evusheld is the new one to help give you protection for 6 months. And keep track of your health. The Crohn's and Colitis Foundation has a wonderful health maintenance checklist for IBD patients. And so this is a nice way for you to have a quick summary. I know some of the newest vaccines may not be on there, but it's at least a good checklist to keep up with your health and at least have a conversation about your doctors. And certainly they'll be staying up to date as changes happen. So thank you so much, and I'm open to any questions during the Q&A.